We're going to start with meeting with and having our new Dean Cardarelli share her COVID vaccination hesitancy in Appalachian Kentucky, the KVAC study. And so, Dean Cardarelli, if you would first introduce yourself, that would be really great. And then if you could share your project, we would really appreciate it. Thank you.
Happy to do that, Lee. Thank you so much for having me. Nice to meet you all. I'm Katie Cardarelli. I am an epidemiologist by training and have really spent 20 plus years of my time doing research on health equity. I have been in Kentucky for almost 11 years now, and so that research is really focused on Appalachian populations. I am new to the University of Louisville. I've been here about 3 months, and I am very interested in building research collaborations here in the city of Louisville, to which I am brand new. But today's presentation is going to focus on an R01 that we're about midway through that is focused on Appalachian populations. And any opportunity that I get to talk about my research, I'm happy to do that. So let me share my screen. And let's see. Let's see. Okay. Is that right, or do I need to switch my display here?
It's showing your next slide, so.
Okay, I'll swap. There we go.
There you go.
Thank you. Okay, so this presentation will focus on COVID vaccination hesitancy in Appalachian Kentucky, and the study, we call it the KVAC study. And KVAC stands for Kentucky Vaccinating All Communities. I have a number of collaborators here. So in addition to UofL, several colleges at the University of Kentucky, as well as the UK's Center for Excellence in Rural Health, are important partners, and that center is located in Eastern Kentucky. We also have the Kentucky Department for Public Health as an important partner, and we have a collaborator at Northeastern University. This particular award is sponsored by NIMHD, and my MPI partner in crime is Mark Kivanimi, who is located at the UK College of Public Health. So I'm sure most of you are aware of this, but the burden of illness and premature mortality in rural Appalachian communities is quite high, and that really puts them at high risk for severe illness and mortality due to COVID. And yet, uptake of the COVID vaccine has been very low in these populations. And in fact, for some of the counties that we're working in, the adult COVID vaccination rates are more than 24 percentage points lower than the national average. We knew going into this grant that COVID vaccine hesitancy is a challenge in this area for a variety of reasons. And so our team definitely saw a need for the development of effective multi-level interventions to address these rates. And so the overall KVAC project goal is to develop effective multi-level intervention strategies, certainly that can be used to address COVID vaccine hesitancy, but we're also very mindful and intentional that the framework that we develop should be scalable and available for a rapid rollout for other infectious disease epidemics. And these are our 15 study counties, and they were explicitly identified because of their very low COVID vaccine uptake levels. So these are our 3 aims for the study. Before I get into them, let me just point out on the right here, we have a framework that those in public health are going to be very familiar with, the socioecologic framework, and it really helps us to think about the factors that impact health behavior and health outcomes that occur on multiple levels. So when we talk about a multi-level intervention, what we mean is an intervention that is explicitly going to occur at least 2 of these levels. And I'm not going to go through any more of the framework, but you can see examples as well of the types of factors that we think about impacting health behavior and health outcomes at these different levels. So AIM-1, we have completed, and I'm going to give you a sneak peek into some of those findings. But we started with some of this qualitative data collection using interviews with key informants in each of our study counties to understand what people knew and thought about COVID and the COVID vaccine, so that we could then take that information and sort of frame it in terms of message content and also trusted communicators to deliver content that would remediate some of the barriers to COVID vaccine uptake in the counties. We also wanted to understand what the structural barriers to delivering COVID vaccine were in these communities. AIM-2 is where we are right now in terms of developing, implementing, and evaluating a multi-level intervention. And so we have been working over many months to develop community-specific multi-level interventions that intervene really on two different levels, that individual level and then at a structural level. And I'll provide a little bit more information about what that looks like as we begin to roll that out really in the next few months. And then AIM-3, we're focused on really a process evaluation, trying to understand the factors that affect reach, acceptance, and implementation fidelity for the different components of the intervention, with the hope that we could essentially scale an intervention like this and or tailor it for different populations. And I also wanted to point out that this is a community engaged study. So we have a community advisory board, and this is a group with whom we meet on a regular basis, sometimes in person, sometimes via Zoom. And really this CAB guides all aspects of the study. We have an AHEC director on there, a hospital administrator, a high school teacher. We have a couple different physicians, a health department director. And so this photo here is a blend of CAB members and investigators. And yes, I do have on a UK shirt because I was employed by the University of Kentucky at the time that this photo was taken last fall. So here's the sneak peek at AIM-1 findings. This is a manuscript that we were very close to submitting. We conducted interviews with 37 leaders in these 15 counties, and we were able to identify barriers and facilitating factors for COVID vaccination. And we organized all of that information by level of the socioecologic model, which I showed you earlier. And then we worked with our community advisory board to translate those AIM-1 findings into a multi-level intervention. And that sounds very simple, but that took many, many meetings occurring over several months earlier this year to actually come up with the intervention, which I, again, will show you here in a minute. So first, let me just point out that there are some direct quotes here at the bottom of the slide that I won't read through, but these are some direct quotes that we heard from our interviews. When it came to barriers to COVID vaccine uptake that we identified through our interviews as it relates to crafting health communication intervention or the messages, we really categorize these into two categories. And I'm going to start on the right. These are the factors that the team decided we can't really control these variables. So we're not going to try to do that in our health communication component of the intervention. Obviously, COVID vaccine is highly politicized. We heard that over and over again. A lot of people are no longer worried about COVID, and so their risk perception is significantly diminished. We heard a lot about government mandates and diminished autonomy. Social media is a highly effective tool for perpetuating disinformation, as well as conspiracy theories. And we heard all sorts of conspiracy theories. We're very mindful that as we start to roll out this intervention over the next few months, that's going to occur during a presidential election. And that will likely be additional fuel for this disinformation, as well as the politicization of the vaccine. And then, we found that a lot of individuals in these communities who are very trusted figures openly do not support the vaccine. And that included a lot of pastors, but it also included nurses and physicians at times. And so that's obviously a big challenge. In terms of factors that we do feel like we can control and we are going to incorporate into our health communication intervention, there were concerns about vaccine safety, the rapid development of the vaccine, uncertainty of effectiveness, and then the ever-changing guidelines. So this is component one of our intervention, which is the health communication component. Again, this was directly informed by our interviews. We are starting with Vaccine 101, which is to say that it's clear to us that people are not clear about how vaccines work and what they are and what they aren't. And then following that, then we will move to helping people understand how they can access the vaccine in their community. And then we will move into the persuasive messaging about advocating for it. Facebook is incredibly important in this community. And so it's going to be a central part of how we push these messages out. And then on the right here, these are direct quotes that we pulled from some of our interviews. In terms of the structural intervention, this is the second piece here. We are focusing on health systems. It's clear to us that the most trusted entity when it comes to health information in these communities is a healthcare provider, particularly a physician. But we also became aware that most physicians in these communities are not talking to their patients about COVID vaccination, and most are not offering the vaccine at this point. But we're treating COVID vaccine much like folks on our team worked on HPV vaccination campaigns in some of these same clinics in rural Eastern Kentucky. And so we will work with health systems to implement sort of systemization of COVID vaccine delivery systems. So first of all, we are going to augment the use of evidence-based techniques in clinics in health systems to encourage COVID vaccine uptake among patients. And we're also going to work with healthcare providers, including some CME opportunities on ways to educate and interact with their patients and with their communities to promote COVID vaccination uptake. So really what we're trying to do here is change the culture around COVID vaccination in health systems in our study communities. So we are going to employ a cluster randomized trial design for this phase of the study. So each of the 15 counties will be randomized to one of the 3 study arms. Arm 1 is the multi-level intervention, so both the health communication and the structural interventions. Arm 2 is just the health communication piece, and then Arm 3 is a controlled. And the control is a delayed intervention condition. So the control will eventually be exposed to at least the health communication component. And so we are going to evaluate the effectiveness in the intervention counties arms 1 and 2 6 months after implementation. And this will occur both with surveys that community health workers are implementing as well as county level data monitoring. So in terms of next steps, actually last Friday, we trained the community health workers in Hazard for data collection. There is a cadre of very talented, experienced community health workers with whom we're working. And these are folks who live in the communities where we're conducting this work. And therefore they are more welcome into the homes for data collection. As I said, we are getting ready to roll out the intervention in the coming couple of months as we move into the fall COVID and flu season. And then following that, we will roll out AIM 3, which is again sort of a process evaluation and more tied into implementation science. So that was a very quick overview of the study, and I don't know if we have time for questions, but I'm also open to inquiries via email, and this is my Twitter handle as well. And I will stop sharing.
Thanks, Katie. That was very informative. I do have one question, and it's possible because I did go in and out with my teams that you mentioned it, and I just didn't catch it. Are there ways that others on campus could tap into what you're doing, or potentially, provide some expertise that you need that you don't have to do this, or even any of your other projects?
Yeah, so the other federal grant that I'm the PI on is actually a food insecurity project that's funded by USDA. I'm definitely looking for collaborators in the food insecurity area. I'm always open for collaborations. Folks that know me well know that to be the case. We have a pretty broad team for the KVAC study that I think covers all the expertise that we need for implementation at this point. But I will say that we are already looking at another R01 that would build on some of these preliminary findings. And so I'm very open to ideas and folks that want to, explore opportunities for working together. And probably the best way to do that would be just to send me an email.
Okay, thank you so much. Welcome
Mhm.
to UofL.
Thank you.
And we're glad we stole you from UK. Okay, so our next speaker is actually from the Speed School of Engineering. It's Dr. Chuan, I can't even talk today, Chuang Chu. And so I'm going to turn it over to him and let him get started. So let's welcome him.
Okay, great. Thanks, Lee. My name is Chuang Chu. I am from Speed School of Engineering. I'm a senior research engineer. I specialize in micro and nano fabrications. So clean room actually and scanning electron microscopes are my best friends. And in this work that I will present the nanofabrication of antimicrobial surfaces with the structures inspired in nature. So this work is mostly inspired by cicadas from Brood 10 that came out 3 years ago in 2021 and also every 17 years. So if you still remember 3 years ago during that time, the cicada is basically everywhere all the time. And noise alert, just to remind you of how the cicadas were working at the time. As a nanofabrication engineer, what I try to do is try to study the nano perspective of the cicadas and see how the cicadas can be integrated into the nano world. So this is what I did. I studied an annual cicada though. It's called the dog day cicada. You can see it appears every year and it has this greenish torso. And what I can find when I put it into the SEM of the wings is that their wings compose of those nanopillar cones. So they look like the bowling pins, as you can see from the SEM images. But they're very, very small. For example, I did some measurements, as you can see here. The height of the nanopillars are about 200 nanometers only. And also the diameter of the cylinders are only 80 nanometers and the base is about only 135 nanometers. And so they are much smaller than the bacteria, which is around 1 micrometers. That just gives it granted the surfaces to have some extraordinary properties. For example, they are super hydrophobic, as you can see from this image, that the water droplet is on top of the cicada wing, the wings, the inner wing and outer wing both. And as you can see, the water doesn't really wet the surface. The water contact angle is over 150 degrees, showing the superhydrophobicity. And the other property is antibacterial. So as you can see here, this is the SEM image that I took on the bottom. And there is the E. coli on top of it. So comparatively speaking, you can see like how those nanopillar cones are, how small they are comparing to the 1 micrometer of the E. coli. So for reference, our hair is about 80 to 100 micrometers. So you can have a view of how small those things are. So what those nanopillar cones do is the mechanism for killing the bacteria is when the bacteria is deposited on top of the surfaces, and it got absorbed, and eventually it got ruptured. As you can see from this schematics in here, you can see they are actually ruptured. You can even say they got punctured. So eventually they got killed. And this is the mechanism of not only the cicada wings, but also some other insects, for example, like shown in here for those images, the dragonfly wings, the Dempsey fly wings, and even gecko skins. They all have this nano features that would be used for really puncturing and physically killing the bacteria. And so those are definitely the inspirations and templates that that appear in nature, and that those inspired us to really see how can we do, how to design all those surfaces so that we can fabricate the similar structures, but for a larger areas, so they can be used in practical applications. So there are certain types of fabrication techniques. If you're not familiar with that, I characterize into two different approaches. One is very simple, to just use the cicada wings as templates. So there are several groups here are doing this molding and remolding thing. So they use PDMS to make the mold out of the cicada wing, and just use the mold to the female mold to become another mold for the actual antibacterial surfaces. But this molding thing just had the problem with not scaling up at all. So because the cicada wing, how big the cicada wing is, the final sample would be that large as well. So there are also ways of using nanofabrication techniques. However, there is a trade-off of using nanofabrication techniques to create the three-dimensional nano features versus the throughput and also the economy. So this is why we are proposing to use a different way to see, oh, how can we address this issue by having a different approach, and also fabricate the cicada wing structures. So this is what we are using. It's called, the fabrication technique is called the glancing angle deposition. So it is a physical vapor deposition process. It's a little bit like 3D printing, but not exactly. But the mechanism is still putting things on top, depositing things on top of the samples. So the mechanism of glancing angle deposition is actually using the shadow effect to create separate nano features. The SEM images are all my samples, old samples showing what GLAD can do. For example, nano pillars, nano springs, zigzags, and also the nano ribbon structures. And glancing angle deposition is also compatible with a variety of materials because we use an E-beam evaporator. So any material, no matter it's silicon dioxide or some metals or carbon, we can all deposit using this technique. Talking about seeds. So if we don't use anything prior to the depositions, then all the nano features that deposited using this method will be randomly distributing on top of the surfaces. They are on nano level. They are very, very small, as you can see from the SEM images. The seeds are, the very, very root is actually sub 10 nanometers, but as they grow up, they can grow bigger. And there's another way of having predetermined seeds, which are some artificial seeds that that prepared before or prior to the depositions to control the flow or to control the deposition patterns. And we can have this more periodical features, separated nano features that on the surfaces. For example, this nano ribbon structure on the bottom right that we can use line seeds, and also for this nano pin, the bowling pin structures, we are having this two different combination of two different parts for the spherical seeds on the bottom bases, and also the cylinders on top of the bases. So the strategy that we had is to use the sphere seeds as the bases, and then deposit using glancing angle deposition to deposit all the cylinders on top of them to really recreate the cicada wing structures. So this is the fabrication process. So this is a little summary. So at first we did a self-assembly of 200 nanometer of the nanospheres. As you can see from the SEM image, that they are hexagonally packed. And then the next thing that we did was etching. So we did use plasma etching to make them not close to each other. And it also resembles the way the cicada wing surface look like. And the next step is to do some depositions, because the spheres are just the base for the nanopillar cone structures. And what we did was to deposit all those pillars on top of the spheres to make them resemble the cicada wing nanopillar cones, the bowling pins, the nano bowling pins. And finally, we added a protection layer just for the robustness of the surfaces and trying to do more of the testings of them. So as you can see, there are some of the numbers down here. Before applying the protection layer, we created the small d of the cylinders to be about 90 nanometers. So it's very close to this 80 nanometer that we are trying to shoot for. So the next thing is the characterization. At first, we did some scanning electron microscopy, and as you can see on the left-hand side, there are actual cicada wing structures appearing again in here. From the tilted view or from the top view, you can see that they the right-hand side are our GLAD samples. You can see from the tilted view and also the top view, they're all look alike. And also the sizes, as you can see, the scale bars, the sizes are very, very similar, because those are the parameters that we choose to go with. So the next thing for the characterization is the hydrophobicity, because as I mentioned, the cicada wings are super hydrophobic. So we did, using the water contact angle measurement, we use the galvanometer to apply 4 microliters of water droplet on top of the cicada wing mimicries. And we find that the water contact angle is about 120 degrees. It's not super hydrophobic. However, it's already, it has a certain hydrophobicity of the surfaces. The third thing that we characterized is the antibacterial property. So this is the procedures of the antibacterial test. So we did only use E. coli as the test bacteria, and we cultivated them and applied them on top of the surfaces, and collected them after incubated them for 4 hours. And we did the optical density measurement, and eventually from the optical density measurement, we got our growth curves. So here are 2 of the growth curves. As you can see, there are many different lines, but the important lines are the sample A and B, and also some positive and negative controls. Those flat curves are just showing there are no E. coli growth at all. This is just showing that our surfaces actually kill the bacteria. And the same story in the SEM image up right here is that you can see there are actually some of the pillars punctured through the E. coli to kill them. This one is for the dilution ratio for 1 to 2, and there's another dilution ratio of 1 to 2. Sorry, there's another duration ratio that we used for 1 to 10 and showed a similar trend and similar story that the E. coli didn't really grow on top of the surfaces. And the SEM image also showed the same story of really puncturing through all the E. coli. So this is the conclusion. Cicada wing nanostructures are analyzed by our SEM and also used as our fabrication template for creating larger area of the replicas. And the replicas have been fabricated by glancing angle deposition with sphere seeds. It's a bottom-up method to build 3-dimensional nanofeature arrays. The design of the sphere seeds are proposed, and also the replica resembles the cicada wing surface nanostructures and the properties as well in terms of hydrophobicity and antibacterial. And finally, the metasurfaces are potentially can be used in household objects and windows, etc. This is not the end of the work. Because the structures, we copied the structures from the cicada wings, but it can only kill the gram-negative bacteria. But one question would be, can we improve the effectiveness, the effective spectrum of the bio-inspired antimicrobial surfaces? For example, can we kill gram-positive bacteria, which has thicker cell envelopes? So the answer would be yes, but I think I have a limited time today, so I cannot get into that. However, our new surfaces are already proven to be effective against gram-negative, gram-positive, and bacteria, and also fungi. So this is just a hook here. The paper is already published. If you are interested, you can contact me, and we can talk about it. Or I can talk about it next time. So acknowledgements. I have several collaborators. Dr. Kevin Walsh and Dr. Seamus McNamara are both from Department of Electrical and Computer Engineering, and Dr. Mark Renning and Mr. Jesse Rosa are from Department of Biology. And also I'd like to thank the NSF funding and MNTC of University of Louisville. And thank you for attention. If you have any questions, you can email me. This is my email address. So thank you.
Thank you so much. And as a layperson, thank you so much for putting it into terms that I could understand. I appreciate it. Sometimes I know it's difficult for researchers to, to make it understandable to others in different disciplines. So I appreciate that. So we have one other presenter, and it looks like we're not that far behind on our time. Again, if you have any questions for Dr. Chu, just please, email him directly, and I'm sure he will be happy to get back to you. So our next speaker is Dr. Bierman, Andrea Bierman from the Spinal Cord Injury Programs, and so I'm going to turn it over to her. Andrea, are you on? Yes, it looks like you are.
All right, and let me know if you're seeing this.
Nothing yet.
Okay, that's not good. Let me go back here.
No, ma'am.
All right, give us a minute. Seems to be stuck. Am I still with you? There we go.
You're here still with us, but I don't see any presentation.
Okay. Very interesting. It worked so well yesterday.
That's okay. It happens always, right? If it would be easier, you could send me the presentation via email and I'll share it.
I don't think the videos and everything will come
Oh.
through to you, but
Okay.
thank you for that suggestion. So everything worked just great yesterday. All
Well,
right, I'll
wow.
take any.
That's okay.
Hey, I'm gonna mute while I try and do this real quick.
Okay, well, while we're waiting on her to get that to work, the other thing that I would like to bring up is that we're always looking for speakers. So if you're interested in sharing your researchers to the campus, please reach out to myself or Cecilia Pareto, and we can put our emails in the chat. We're always looking for speakers. We do meet monthly. It's always the last Thursday of the month. Okay, it looks like, Andrea, we can see it. You're not in slideshow mode, but you're up. So what we can see is conflict of interest financial disclosures.
You're muted, Dr. Behrman. And you're not in presentation view either.
How about that? How about that?
That
That
looks
works.
better.
Hey, all right. Looks better, meaning it worked.
Yes, it does.
Okay. All right, we're good to go then. All right, so thanks very much. There's a conflict of interest slide relative to being a volunteer president for a non-for-profit, co-author of a text on principles I may discuss today, and medical devices we use that are licensed by the university. All right, just to give you a background. So I came here in 2012 from the University of Florida to become part of the Kentucky Spinal Cord Injury Research Center. And it already had a basic science component and an adult component for translational research, but no pediatric program. And so I came here to fill in that gap. One of the first things we did on the right, you can see, is we developed a pediatric neurorecovery clinic for children with spinal cord injury embedded in Fraser Rehab. The difference there is this clinic uses evidence-based practice to promote recovery after injury, and that's pretty novel to expect recovery. The other aspect was with the Spinal Cord Injury Research Center is our aim is to develop cutting-edge research in children with SCI to promote recovery, but also to accelerate that translation into practice. We have a database that allows children worldwide the opportunity to participate in research. As you can see in the overlap in the middle, 75% of our clinic patients also participate in research. We have a 93% clinic attendance rate and probably greater for even research attendance compliance. We have children from 7 months to 18 years who participate from 31 states and 9 countries, and 13 families have relocated here to participate in this program. Let me mention, I'm a physical therapist and a researcher of motor control. I'm speaking today on behalf of our research program and our translational program staff. So the key thing is to think about this as an emerging paradigm shift. As I mentioned, the predominant method of rehabilitation for children and adults with spinal cord injury doesn't predict any kind of recovery. And so the rehab is based on compensation for paralysis or adaptation to all the impairments or the consequences of spinal cord injury. But the work we've been doing has been based on work here at the University of Louisville, in particular the adult program that has been implanting epidural stimulators or spinal stimulators on the epiderm of the spinal cord in adults. Up to 50 individuals have had this done. Now, there's not only neuromuscular control that has improved, but also other physiological systems. Today, I'm just talking about motor control. So this work came out in 2018 of 4 individuals who've been implanted. The key aspects, as you can see here, that you can gain the ability to sit upright with training and the device, and even walk over ground. Key to this is this can only happen when the stimulator is on and requires training to do so. So one of the key principles that was learned from this, because these were individuals that are motor complete, unable to voluntarily initiate any kind of motor control below their lesion. And what they learned from this is that the physiological and biochemical state of the spinal cord will affect how it responds to any given therapeutic intervention. So what does the stimulation do? It changes the state of the spinal cord. It raises the state of excitability, which ultimately improves its ability to respond to both afferent input as well as descending control. And so if we look at our old model for spinal cord injury and potentially a new lens on how to rehabilitate persons, we can understand that with a lesion in the spinal cord, we've interrupted that intent in our ability to control below the lesion, and our descending input and drive has been interrupted. Since then, we've developed therapies which take advantage of the afferent input to the spinal cord, and that the spinal cord will actually respond to sensory motor input to help generate movement below the lesion. And we've done that for over 20 years. What this group with epidural stimulation is introduced the idea that you can change the state of excitability of the spinal cord with stimulation and ultimately improve its ability to respond to descending input as well as to afferent input. Now, we're working with children. The spinal stimulators are not FDA approved yet for any function. And so it'll be a long time before we think about implanting these in a growing neuromuscular system such as children. So we were looking for a non-invasive way to also provide that stimulation. And colleagues Yuri Gerasimenko has developed a transcutaneous spinal stimulator. What that means is we can provide the stimulation on the surface of the skin, and through activation of sensory and motor fibers, we can activate that spinal cord, raise its state of excitability, and very similar to the epidural stimulator, improve the excitability of the nervous system, lower the threshold for activation, and increase the probability of a motor response below the lesion, even in people with motor complete injuries. So what you're going to see here is an individual about 12, maybe 14 years of age who has a low cervical, high thoracic injury. He was injured at 2 years of age, so very chronic. He has on him now surface transcutaneous spinal stimulation at the T11 spinal segment. You're going to watch the video over time. In this study, we're just establishing the safety and feasibility of using spinal stimulation, surface spinal stimulation, to augment trunk control in children. NIH isn't going to move ahead with any kind of study in children unless it's been shown to be safe in that population. So we examine the known risk as published in adults. This is a cross-sectional study. Children just participated over 3 days. It wasn't a treatment intervention. It was an acute response to the stimulation. If you look at the 3 figures on the right, they'll show on the bottom, the purple one shows the increase in stimulation across time. The center one is the change in his center of pressure over his seat as he becomes more upright. And the third shows at the top shows the kinematics with going from a very flexed posture to upright. We looked at things like skin irritation under the electrode. That happens, but it dissipates in approximately an hour. The children didn't like the stimulating pad. If we put it at the neck, that's a highly sensitive area. There was potential for also leg movement during the stimulation, but we had a high compliance rate. We only had one child that didn't complete because she had something called allodynia, which is a high sensitivity at her lesion level, which was quite low. So she had a negative response to the stimulation. Overall, though, we had a high compliance rate for attendance, and this is the effect we can see on an acute basis. So what we use that information in our work with something called activity-based locomotor training, which is a sensory motor therapy, to develop a combined therapy. And what we're doing is an efficacy study funded by the Craig Nielsen Foundation in 12 children aged 4 to 12, looking at the response on motor controls, particularly posture, the rate of change, the durability of the effects, and ultimately the mechanisms for that change. So it's an ongoing study. We've had 7 children complete that study so far. We're also interested in the potential to recover walking. This was a particularly challenging because we're taking children again with motor and sensory complete spinal cord injury, age 4 to 12. They all have chronic spinal cord injury, no capacity to voluntarily move below the lesion. It's been years since they've been injured, but their spinal cord can respond to specific stimulation of the spinal cord and showed lower limb responses to that. So in this study, children participate. They have 20 sessions alone in what's called a gravity neutral environment. They go through passive movements of their limbs with stimulation where they're not paying attention. In another session, they're also stimulated, same session, but asked to pay attention and try to move their limbs. And then we remove the stimulation and ask the child to move. This is done in the gravity neutral. We move to a treadmill environment, and then we move to an overground environment using the same sequence. The stimulation is provided at 3 different segments of the spinal cord, T11, L1, and in the coccyx area. So this is a demonstration of that with the stimulation on. Someone's passively moving the top leg, and the stimulation is on. We're asking the child on the video on the right to participate. Most of the activity came from the hips, not really the lower leg or the ankles during this activity. After 20 sessions, we introduced the child to the treadmill environment. He's provided partial body weight support. We have trainers that are facilitating and assisting with the movements. And here he's just being asked to, he's being asked to kick a ball. We have a surface like a ripstop surface below that helped reduce friction, so he could do that. But also, ultimately, we're training to swing the leg through as with ambulation. So he's doing this fully on his own. The stimulation is off now. And then we ultimately take that to overground. Again, the stimulation is off. If you'll note, he's very easily able to move his right leg through, but has challenges with his left leg. That didn't happen every day. It alternated. What he was able to do, you'll see in a minute, he struggles with the right leg for a second, but then he gets it right back and can swing that leg through. All 6 children who participated in this study ultimately could swing their legs through actively, voluntarily, and were able to sustain that without stimulation, sustain that ability 3 months, even 6 months later. One of the other byproducts of this is the fact that there are other systems that may be benefiting. So this family, I just met with them. It's 2 years later. During the study, he started to recover bladder sensation. Now he has full bladder sensation, knows exactly when he needs to go to the restroom. So another, again, a byproduct. And lastly, in this third study, again, that starts from the clinic. What we've learned from the clinic is that over the past 10 years, or 12 years, in fact, we've had 10 children who came to us with perinatal spinal cord injury, meaning that that happened in utero. 6 of those children have very high cervical lesions. And it turns out they behave very differently than a children, or present very differently than a children with a mid to lower cervical injury. They're at high risk for scoliosis due to their rapid development. These children develop in the context of spinal cord injury. This child had one of the high cervical injuries. And although we're making a big impact with them through the current therapies we have, as you can see here, and even here with changes in mobility from being non-ambulatory, unable to stand or sit, to being able to walk with a walker, we think we can do better. And so we have a grant from the Kentucky Spinal Cord and Head Injury Research Trust Research Board to do so. We're collaborating with colleagues from Vanderbilt, who is a radiologist. Dr. Smith is going to be imaging the pediatric spinal cord. There are probably only 5 specialists in the world who do that. And Ronaldo Ishiyama from the University of Leeds in Great Britain was one of the early researchers with Yuri Gerasimenko to develop the epidural spinal tip stimulation in the animal model. He has also tested that in neonatal rat model, and so is very key to working with us using transcutaneous spinal stimulation. So thanks very much from the Cozier for Kids Center for Pediatric Neurorecovery. As others have said, with us expanding to looking at whole body systems in these children, beyond just the motor control, but bowel and bladder, autonomic, etc. We welcome collaboration from others. Thanks very much.
Thanks, Andrea. This is very exciting, and Andrea actually invited me to meet with a few of her patients and their families, and I was very impressed. And it's not only the work that she's doing around the spinal cord injuries for children, but it's really, really a very positive experience for the parents and the families, as you can imagine, to have a child that is, they've been told would never be able to do any of these kind of activities, to actually have a program where there is some potential and possibilities. And so for them, that's very much a positive impact. And so I think it's a great program. Thank you for sharing. I know that John is on, but I'm not sure if he's going to be able to jump in. He did say that he was muted earlier. John, are you available to touch base real quick? Doesn't seem like it, does it? All right, so the last things on the agenda I have also placed in the chat, because I wasn't sure we would actually get to them due to the amount of time presenters needed. I just wanted to make first some clarification around eligibility at the university. A lot of people typically reach out to me this time of year to find out if we are eligible to submit proposals to the NSF EPSCoR E-Core program and the E-RISE. And recently, the University of Kentucky did receive an award for their Track 1. And so that means that we are not eligible for the E-Core or the E-RISE. And so if you could pass that along to any colleagues that you know that are interested in that program, that'll save me some emails. The other, but more just as important piece is that we will be doing a research retreat for new researchers and researchers new to UofL on September 13th at the Shelby campus. And this will be the first year that we're going to do a program that will be a day long. However, when I say day, I'm not sure the actual time frame. But the goal is to bring together researchers from both the health science campus and the Belknap. In the past, we have broken and done orientations separately. So we're trying to mix that up. We hope to have the registration for that event to go out mid to late July. So please pass that along to anyone that you know that is new and coming on board here in the fall. I've also highlighted a webinar that's coming up around the NIH Fellowship Application Program. And then, just wanted to remind you there are major changes to the NIH review criteria and other programmatic changes that will take place or go into effect in January. And we'll provide some more information about that as we get closer. And then the last one here was just an article that I found very interesting and thought that some of the faculty that participate here may be interested, particularly if they typically submit to NSF. The governing board is considering expanding the broader impacts review criteria to be called societal impacts, with a few little nuanced changes around the definition. And then most importantly, make that a separate review criteria that actually becomes part of the overall impact score. So just a little, if you're interested in that, keep your eyes out. I mean, nothing has been published as a change, but something to watch for. And I think that puts us 1 minute over. Does anyone that's still on have any questions for us? All right. If not, I hope everyone has a wonderful afternoon, and thank you again for joining us. See you next month.